Welcome to the MRCpology channel for a quick review, understanding, and revision of the topic. Imagine a patient who develops progressive weakness of one hand. The muscles become wasted, fasciculations appear, and yet the reflexes in that same limb are brisk. Sensation remains normal. This combination of lower and upper motor neuron signs should immediately suggest amyotrophic lateral sclerosis. Before discussing motor neuron disease, let us briefly understand the normal motor pathway. Voluntary movement begins in the primary motor cortex. The upper motor neuron descends through the internal capsule and brainstem into the corticospinal tract. Most fibers cross in the lower medulla and continue down the opposite side of the spinal cord. Within the spinal cord, the upper motor neuron synapses with a lower motor neuron in the anterior horn. For muscles supplied by cranial nerves, it synapses with lower motor neurons in the motor nuclei of the brainstem. The lower motor neuron then leaves the spinal cord, or brainstem, travels through a peripheral nerve, and reaches the neuromuscular junction. Acetylcholine is released, the muscle fiber depolarizes, and contraction occurs. So the pathway is simple: motor cortex, upper motor neuron, anterior horn cell or brainstem motor nucleus, lower motor neuron, peripheral nerve, neuromuscular junction, and finally the muscle. The basal ganglia help initiate and regulate movement, while the cerebellum coordinates movement, balance, and accuracy. However, motor neuron disease mainly affects the upper motor neurons, lower motor neurons, or both. Motor neuron disease is a progressive neurodegenerative disorder affecting the motor system. Sensory pathways are usually preserved, which explains why sensory symptoms are absent or minimal, particularly early in the disease. Cerebellar signs are also not expected. The commonest form is amyotrophic lateral sclerosis, or ALS, in which both upper and lower motor neurons degenerate. Let us first consider upper motor neuron degeneration. Upper motor neurons normally provide descending control over spinal motor circuits. When they degenerate, this control is lost, and the spinal reflexes become disinhibited. The result is increased tone, brisk reflexes, clonus, and an extensor plantar response. The weakness is spastic rather than flaccid. Now consider lower motor neuron degeneration. Lower motor neurons arise from the anterior horn cells of the spinal cord or the motor nuclei of the brainstem. Their axons directly supply skeletal muscle. When these neurons degenerate, the muscle loses its nerve supply. This causes weakness, wasting, fasciculations, cramps, and reduced reflexes. In amyotrophic lateral sclerosis, both systems may be affected in the same region. A patient can therefore have muscle wasting and fasciculations from lower motor neuron loss, while also having brisk reflexes and spasticity from upper motor neuron degeneration. The key clue is this unusual combination of upper and lower motor neuron signs. Fasciculations and fibrillations should not be confused. Fasciculations are spontaneous contractions of entire motor units and may be visible beneath the skin. Fibrillation potentials represent spontaneous activity in individual denervated muscle fibers. They are not usually visible clinically and are detected on needle electromyography. As motor neurons are lost, surviving neurons attempt to reinnervate nearby muscle fibers through collateral sprouting. This produces enlarged and unstable motor units, explaining both fasciculations and the chronic neurogenic changes seen on electromyography. At the cellular level, several mechanisms contribute to motor neuron degeneration. The first is abnormal protein folding and aggregation. TDP43 is the most common pathological protein in amyotrophic lateral sclerosis. Other important proteins include SOD1 and FUS, particularly in inherited forms. The second mechanism is glutamate excitotoxicity. Excessive glutamate stimulation causes increased calcium entry into the neuron, leading to mitochondrial damage, enzyme activation, oxidative stress, and eventually neuronal death. The third mechanism is mitochondrial dysfunction. Motor neurons have long axons and high energy requirements. Failure of ATP production makes them particularly vulnerable. Impaired axonal transport also contributes. Proteins and organelles must travel long distances from the cell body to the neuromuscular junction. When transport fails, the distal axon degenerates and the muscle becomes denervated. Microglia and astrocytes may also release inflammatory substances, creating a toxic environment that accelerates neuronal injury. Most cases are sporadic. Important familial causes include mutations or expansions involving C9orf72, SOD1, TARD-BP, and FUS. C9orf72 is particularly associated with the overlap between amyotrophic lateral sclerosis and frontotemporal dementia. Clinically, amyotrophic lateral sclerosis usually begins with progressive, asymmetric weakness. A patient may notice difficulty turning a key, fastening buttons, writing, lifting the foot, or climbing stairs. The weakness gradually spreads from one region to another. Lower motor neuron signs include wasting, fasciculations, cramps, flaccid weakness, and reduced reflexes. Upper motor neuron signs include spasticity, brisk reflexes, clonus, and extensor plantar responses. MRCP trap do not exclude amyotrophic lateral sclerosis because the reflexes are brisk in a wasted limb. Wasting with brisk reflexes is a classic clue to combined lower and upper motor neuron disease. Bulbar involvement causes dysarthria, dysphagia, nasal speech, choking, tongue wasting, and tongue fasciculations. Lower motor neuron bulbar involvement produces a wasted and fasciculating tongue. Upper motor neuron corticobulbar involvement produces a stiff tongue, brisk jaw jerk, spastic speech, and emotional lability. Respiratory involvement occurs because the diaphragm and accessory respiratory muscles lose their motor supply. Early symptoms include orthopnea, disturbed sleep, morning headaches, vivid dreams, daytime sleepiness, and fatigue. These symptoms often reflect nocturnal hypoventilation and carbon dioxide retention. The key treatment is non-invasive ventilation, usually with bilevel positive airway pressure. MRCP trap, respiratory failure in motor neuron disease is primarily a ventilation problem. Oxygen alone may improve the oxygen saturation without correcting carbon dioxide retention. The patient requires ventilatory support. Sensation is usually preserved because sensory pathways are not primarily affected. Eye movements and sphincter function are also generally preserved until late. Prominent sensory loss, early bladder disturbance, ophthalmoplegia, or marked pain should make the clinician reconsider the diagnosis. Cognitive and behavioral impairment may occur, particularly as part of frontotemporal dementia. Patients may develop apathy, disinhibition, loss of empathy, impaired judgment, or language difficulty. Now let us distinguish the main clinical patterns. Amyotrophic lateral sclerosis is the commonest form and involves both upper and lower motor neurons. The typical patient has asymmetric weakness, wasting, fasciculations, brisk reflexes, and spasticity. Bulbar and respiratory involvement often develop later. Progressive bulbar palsy begins with predominant involvement of the bulbar motor neurons. Patients develop dysarthria, dysphagia, nasal speech, choking, tongue wasting, and tongue fasciculations. Emotional lability may appear when the corticobulbar pathways are affected. Many patients later develop a more generalized amyotrophic lateral sclerosis pattern. Progressive muscular atrophy is predominantly a lower motor neuron disorder. It causes flaccid weakness, wasting, fasciculations, cramps, and reduced reflexes without clear upper motor neuron signs initially. Progression is often slower, although upper motor neuron signs may appear later. Primary lateral sclerosis is predominantly an upper motor neuron disorder. It produces progressive spastic paraparesis or quadriparesis, brisk reflexes, clonus, extensor plantars, and sometimes pseudobulbar effect. Wasting and fasciculations are minimal, and progression is usually slower than in classic amyotrophic lateral sclerosis. The diagnosis of motor neuron disease is mainly clinical, supported by electromyography, while excluding treatable mimics. Electromyography demonstrates active and chronic denervation in several regions. Active denervation produces fibrillation potentials and positive sharp waves. Chronic denervation and reinnervation produce large, long-duration motor unit potentials with reduced recruitment. Nerve conduction studies usually show normal sensory responses because sensory nerves are preserved. Motor responses may be reduced because motor axons have been lost, but conduction block should not be present. Do not confuse amyotrophic lateral sclerosis with multifocal motor neuropathy. Multifocal motor neuropathy can also cause asymmetric weakness without sensory loss, but nerve conduction studies may show motor conduction block. This is important because multifocal motor neuropathy may respond to intravenous immunoglobulin. Magnetic resonance imaging of the brain and spine is used mainly to exclude structural disease. Cervical myelopathy is an important mimic. It may cause wasting and weakness in the hands, with spasticity and brisk reflexes in the legs. Neck pain, sensory abnormalities, Bladder symptoms or a clear compressive lesion on imaging favor cervical myelopathy. Blood tests are performed to exclude alternative diagnoses. These may include creatine kinase, vitamin B12, thyroid function, HIV testing, Lyme serology where appropriate, and autoimmune or paraneoplastic investigations in atypical cases. Red flags against motor neuron disease include prominent sensory loss, marked pain, early sphincter dysfunction, ophthalmoplegia, major fluctuation, definite conduction block, and a clear response to immunotherapy. Treatment combines disease-modifying therapy with multidisciplinary supportive care. Riluzole provides a modest survival benefit, probably partly by reducing glutamate-mediated excitotoxicity. Liver function should be monitored during treatment. Edaravone may be considered in selected patients according to local eligibility criteria. Respiratory function should be monitored regularly. Non-invasive ventilation is used for nocturnal hypoventilation or significant respiratory muscle weakness and can improve symptoms, quality of life, and survival. Swallowing and nutrition should be assessed early. Dysphagia can cause aspiration, dehydration, and weight loss. Dietetic support, texture modification, nutritional supplements, and gastrostomy may be required. Gastrostomy should ideally be discussed before respiratory weakness becomes severe. Speech and language therapists help with swallowing and communication. Patients may benefit from communication boards, voice banking, text-to-speech systems, or eye gaze technology. Baclofen or tizanidine may help spasticity. Anticholinergic medication or botulinum toxin may be used for troublesome sialorrhea. The excessive drooling is usually caused by impaired swallowing of normal saliva rather than excessive saliva production. Genetic counseling and testing should be considered in familial disease, early onset disease, or when frontotemporal dementia features are present. Early palliative care involvement can support symptom control, communication, advanced care planning, and the needs of both the patient and the family. If you remember one thing, remember this. Amyotrophic lateral sclerosis classically produces progressive motor weakness with both upper and lower motor neuron signs, while sensation remains relatively preserved. Quick recall. A patient has progressive hand wasting and fasciculations, but the reflexes in the same arm are brisk and the legs are spastic. Sensory examination is normal. What is the most likely diagnosis, and why are the reflexes brisk despite the wasting? The answer is amyotrophic lateral sclerosis. The wasting reflects lower motor neuron degeneration, while the brisk reflexes reflect simultaneous upper motor neuron degeneration. A patient with motor neuron disease develops orthopnea, morning headaches, disturbed sleep, and daytime somnolence, despite an almost normal daytime oxygen saturation. What is the likely problem, and what treatment is required? The answer is nocturnal hypoventilation caused by respiratory muscle weakness. The patient requires respiratory assessment and non-invasive ventilation rather than oxygen alone. Do subscribe to the channel for further videos. Sorry, we forgot to include progressive bulbar palsy. This is also one of the recognized types of motor neuron disease. In progressive bulbar palsy, the bulbar motor neurons are affected early, involving the motor nuclei in the medulla and sometimes the corticobulbar pathways. Patients typically develop dysarthria, dysphagia, nasal speech, choking, and difficulty handling secretions. Lower motor neuron involvement causes tongue wasting and fasciculations, while corticobulbar involvement may produce emotional lability as part of a pseudobulbar picture. The key point is that the disease begins predominantly with speech and swallowing problems, but it often later spreads to involve the limbs and respiratory muscles, developing into a more general amyotrophic lateral sclerosis phenotype.